Hello, everyone. Welcome to your Culturally Sensitive Care lecture. This lecture will once again cover key concepts from your chapter, but please go ahead and read the assigned chapter listed in your module. These are the learning objectives that we will be covering. Please take some time to review them. What is culture? Culture is a shared system of beliefs, values, and behavioral expectations that provide social structure for daily living, right? This is our language, the manners in which we interact, how we communicate, the rituals, our roles, customs, relationships, practices, values, and thoughts that belong to the culture that we grew up in. These are some important definitions related to culture. For example, cultural assimilation, culture shock, ethnicity, race. Culturally congruent care. This is important for you to know. It's also called transcultural care, right? And it emphasizes the need to provide care based on an individual's cultural beliefs, practices, and values. So this is when we provide care based on our patients' cultural beliefs, practices, and values, not ours. Cultural competence or sensitivity. Being culturally sensitive, culturally appropriate, and culturally competent to meet multifaceted healthcare needs of each person, family, and community. These are the five constructs of the model of cultural competence, things that we can do to develop cultural competence. The first one is cultural awareness. Right? This is the process of conducting a self-examination of our own biases towards other cultures and exploring our own cultural and professional background. It also involves being aware of the existence of documented racism and other isms in healthcare delivery. What is cultural knowledge? This is the process in which a healthcare professional seeks and obtains sound educational base about culturally diverse group. In acquiring this knowledge, the healthcare professional should focus on the integration of three specific these issues: health-related beliefs and cultural values, care practices, and disease incidence and prevalence. This is cultural knowledge. Cultural skill. What is cultural skill? It's the ability to conduct a cultural assessment of a patient and collect relevant cultural data about the patient's presenting problem, as well as accurately conducting a cultural-based physical assessment. So this is a skill that a nurse should have, which is conducting a proper cultural assessment, physical, and collecting a cultural history. Cultural encounter. This is a process that encourages healthcare professionals to directly engage in diverse backgrounds, right? And cultural encounter aims to modify our existing beliefs as a nurse about a cultural group and to prevent stereotyping. It's like creating those encounters with people from different cultures and backgrounds so we can change ourselves, like we can provide the care based on their culture. Cultural desire. This is the motivation of the nurse to want to and to have to engage in becoming more culturally aware, culturally knowledgeable, and culturally skillful, and seeking cultural encounters. Cultural diversity. Please read over these definitions. They're important. Intersectionality. What does that even refer to? It refers to simultaneous experience of categorical and hierarchical classifications, including but not limited to race, class, gender, sexuality, and nationality. Worldview. What is the worldview? It's a set of assumptions that begins to develop during childhood and guides how one sees, thinks about, experiences, and interprets the world. It basically creates a lens through which we view all of life's experiences through our own uniquely tinted view. Our worldview evolves during a lifetime process of interacting with family, peers, communities, organizations, media, and institutions. It's very important for you to advocate for patients based on their worldviews. This requires thorough ongoing assessment, flexibility, and planning in partnership with each patient. Like you include the patient in the plan of care to ensure that your care is safe, effective, and culturally sensitive. Before I go on to explain emic worldview and the etic worldview, let me share an example. For example, a Korean woman requests seaweed soup for her first meal after giving birth. This request puzzles the nurse. The nurse has an emic worldview of professional postpartum care, but is an outsider to the culture of the Korean lady, right? So she has an insider perspective of postpartum care in her healthcare environment, but she has an outsider view of the Korean culture. As such, the nurse isn't aware of the meal's significance to the patient. She doesn't understand why is it important for her to have seaweed soup. We don't usually do that, right? So conversely, the Korean patient has an etic worldview of the American professional postpartum care and assumes that the seaweed soup is available in the hospital. So for the Korean patient, she assumes that it should be there, right? But seaweed soup can be very expensive and not readily available. I mean, we don't always have seaweed soup in the hospital, right? And so the nurse might offer a substitute of other greens such as kale, right? Now, conflict arises when the healthcare providers interpret the behaviors of these patients to their own worldview lens, instead of trying to uncover the worldview that guides the behavior of the patient. So it's extremely important for us to understand what is their worldview, right? And not judge them based on our worldview. It's very important for us to take that into consideration. Let's look at another example. While preparing for clinical, you learn that Muslims differ in their adherence to tradition, but that modesty is an important Islamic ethic that pertains to interaction between the sexes, right? So thus, you say to your patient, I know that for many of our Muslim patients, modesty is very important. I want to respect your beliefs. Is there some way I can make you more comfortable? Right? You do not assume that the information will automatically apply to this patient. Instead, you combine your knowledge about that cultural group with an attitude of helping and flexibility to provide quality patient-centered care, which is called culturally congruent care. And you did this by identifying that every time she was being provided care by a male, she was uncomfortable. Right? And this is how we as nurses identify the differences, and we try to help. We try to be culturally congruent and not stereotype and say, oh my God, seriously? You know what? We only have male care providers, so, just deal with it, lady. No, we try our best to provide culturally congruent care. That is our role as a nurse. What inhibits diversity, right? What are the factors that inhibit it? Stereotyping, the dangers of assuming. When one assumes that all members of a culture, ethnic group, or race act alike, positive or negative. Negative stereotyping includes racism, ageism, and sexism. For example, like, oh, yeah, that person, they're older, so of course they're going to act like this. Oh, they're a teenager, so of course, you know how they act. This is negative stereotyping. It's making generalizations that everybody from a certain culture or everybody of a certain age acts a certain way, because that is your worldview, right? Those are your biases that you have to identify. For example, in the situation with the Korean patient and the seaweed soup, the nurse should be careful not to stereotype her, right? And try to understand her worldview. What are these biases? These biases can be explicit or they can be implicit. It's very important for you to know what these biases are and the differences. Explicit bias is expressed directly. You are aware of your bias and you operate and you practice it consciously. You know you're biased and you're not afraid to say it, right? For example, I like whites more than Latinos. That's an explicit bias. When somebody says that, that's explicit. Now you know that that's their bias. What is an implicit bias, right? It's expressed indirectly. You're trying not to show it, but you have that bias in you, right? But you're trying not to show it. You might even be unaware of that bias, right? We might be unaware, completely unaware that we have that bias in us, right? It operates subconsciously deep inside us. And it could be a factor of our worldview or how we grew up, our customs, our culture, right? An example of that would be sitting further away from a Latino than a white individual. So now you're not openly saying it, but you are subconsciously still have that bias and you sit further away from a person who's Latino than a white. These are other important definitions that you should also read over. Cultural conflict and cultural imposition. These are two that I want to talk about. Imposition, tendency of some to impose their beliefs, practices, and values on another culture because they believe that their ideas are superior to those of another person or group. For example, in the case of the lady who requested the seaweed soup, right? And say I'm from a certain culture and I say, you know what, in my culture, we eat this and this would work better. So you should try this. Now you're imposing your culture on them. And that's not right. And that is not appropriate. It's not culturally congruent care. Cultural conflict, a situation that occurs when people become aware of cultural differences, feel threatened, and respond by ridiculing the beliefs and traditions of others to make themselves feel more secure about their own values. For example, in the same example with the seaweed soup, now you have the cultural conflict, right? Then we would say, okay, well, I feel threatened by it. I always thought drinking chicken soup, for example, in my culture is what we're supposed to do. So now, how do we deal with it? We deal with it by ridiculing that person and saying, yeah, right, that seaweed soup, that's ridiculous. Nobody does that. And so that's cultural conflict. Now, there's some cultural influences that have an influence, cultural influences on healthcare, I'm sorry. What are these? Physiologic variations. Certain racial and ethnic groups are more prone to being diagnosed with certain diseases, right? They have physiological, variations. For example, you have diabetes in your family. You have African Americans, the heart disease is much higher in African Americans, and these are statistics, right? Please read over this table 5.1 in chapter 5, and it shows the different ethnicities and common healthcare problems in each. Reactions to pain. Some cultures allow or even encourage the open expression of emotions related to pain. Some cultures encourage to suppress it. They would be like, hey, stop, just deal with it. Pain is a part of life, right? Do not assume that the patient who does not complain of pain is not having pain. Be sensitive to nonverbal signs of discomfort. If you see the nonverbal signs of discomfort on them, then recognize those cues, treat the pain, talk to them, ask them, rate their pain, right? Do not consider patients who freely express their discomfort as constant complainers with excessive requests for pain relief. Nurses tend to do this. It's like, oh, his call light is on. Guess what he wants? Pain pills, That is, not culturally congruent care, right? What can we do, right? We can recognize that culture is an important component for each person. Respect the patient's right to respond to pain in their own manner, not the way we feel is right, right? Never stereotype a patient's perceptions of or responses to pain based on the person's culture. Never do that. Avoid stereotyping. Mental health. Many ethnic groups have their own patterns of behavior for psychological well-being and psychological reactions to certain situations, right? For example, Hispanics deal with problems within the family and consider it inappropriate to tell problems to a stranger. In the Chinese culture, they consider mental illness a stigma and seeking psychiatric help as a disgrace to the family. In Puerto Rican culture, in times of high stress or anxiety, they may demonstrate a hyperkinetic seizure-like activity known as attacks, right? This behavior is culturally accepted reaction. So every culture deals with mental health very differently, right? What can we do as nurses? Be aware of these variations and accept them as culturally appropriate. Once again, providing culturally congruent care. Assigned sex roles. In some cultures, the man is the dominant figure and makes decisions for all family members, and women are passive. In some cultures, women are dominant, right? When the dominant member is ill and can't make decision, this leads to the family being anxious and confused. And that is something we see in practice in healthcare all the time. The family is confused, they're anxious because maybe the patient was the dominant, role in the family. What can you do? Know who the dominant family member is. Just recognizing that would help a lot. Language and communication, right? In the US, we have a very diverse culture. We have a lot of languages. Communication problems can arise during healthcare activities. Imagine you're in an emergency room with crushing chest pain in a foreign country where no one speaks your language. It's a very vulnerable position to be in. It's important for nurses to be linguistically competent. The ability of caregivers and organizations to understand and effectively respond to the linguistic needs of patients and their families in a healthcare encounter. That is their right to receive language services when needed. What can the nurse do in this case? If you work in an area where people speak a different language, learn pertinent words and phrases. Use a qualified interpreter. No need to speak loud. You don't have to scream at the patient. It's a language problem, not a hearing problem, right? Be familiar with linguistic resources available in your facility. Orientation to space and time. Personal space is the area around a person regarded as a part of the person. It is individualized to each person and to different cultures and ethnic groups. It's the area into which others should not intrude during personal interactions. Some examples. Middle Eastern and African cultures sit and stand close to one another when talking, right? Asian and European cultures prefer more distance between themselves and others, right? So if they have an encounter with a Middle Eastern person, they might feel that person is in my space, right? But that's a cultural thing. Punctuality, orientation to time. In the United States, it's considered a sign of respect. In South Asia, being late is considered a sign of respect, right? But what can the nurse do in this case, right? Do not intrude in personal space. Learn about their culture, ask and find out what is appropriate and what is inappropriate. Don't assume that just because in your culture it's okay to be really close to somebody in their personal space, that the patient should be okay with it. Know that patient's cultural, personal space preferences. Food and nutrition. Certain food groups serve as staples of the diet based on culture, and clients do not have much choices when they're in the hospital, right? We're used to certain foods, and when we go to the hospital, you want the patients to feel, at home, because that will help their healing. But at the same time, you can't provide them with what they're always used to, right? For example, the seaweed soup, right? We don't always have that available in a can that you can heat up and provide, right? So look for alternatives. And this is what you can do as a nurse. Determine whether the problem may be related to culture, first of all. Allow the family to bring in food when permitted, if the doctor allows it. Provide individualized dietary teaching, right? catering to them, providing alternatives that are close to what they're used to. Family support. In many cultural and ethnical groups, people have large extended families and consider the needs of any family member to be equal or greater than their own, right? So every culture is different. They may be unwilling to share private information about family members with those outside the family, including healthcare workers. In some cultural groups, they have great respect for the elders in the family and would never consider institutionalizing their care. For example, in some cultures, they're not going to put their elderly in a nursing home. In some cultures, it's appropriate, right? In some cultures, when somebody is sick, a lot of family members, they're at the hospital and everybody wants to see that person. When my brother, was in the ICU and, during his last moments, there were a lot of people there. There were about 60 to 75 people in the hospital lobby, wanting to see him. And the ICU made an effort to accommodate everybody, not at the same time, but we have to take 2 to 3 people in at a time to go see him. And it showed how that their cultural sensitivity, instead of judging the person, saying, okay, this is ridiculous, this should not be happening. So that is how, as nurses, we include the family in planning and we provide culturally congruent care. Socioeconomic factors and health disparities. Low income is a major problem in the United States and is often described as having created a culture of poverty, right? And what can the nurses do, right? We can facilitate access to health care and advocate for your patient, and you see this in healthcare. Unfortunately, we see this a lot where you have patients who are homeless, they're on the streets and they come in and, their skin, they have a lot of skin issues. Their feet don't look like the way we would like to see them, right? And nurses judge, we tend to judge them and we say, look at them, they don't even take care of themselves, they're always asking for food, and they're always this, they don't deserve this, and so we have to be very careful. We have to advocate for our patient. They are our patient, and it is our ethical responsibility to advocate for our patient. This is a transcultural assessment model, and it kind of explains, lists things that different ways in which we can provide culturally appropriate assessments. Cultural respect, providing care with cultural respect. Let's talk a little bit about that. Cultural influences on health and illness. Some beliefs include illnesses are classified as either natural or unnatural. Natural illnesses cause dangerous agents such as cold, air, impurities in the air, water, or food. Unnatural illnesses are punishments for failing to follow God's rules, resulting in evil forces or witchcraft, or causing physical or mental health problems. The power to heal is a gift from God bestowed on certain people. Folk or traditional healers use divine interventions to heal, right? Herbs are a common method of treatment. Other traditional therapies, cutaneous stimulation, therapeutic touch, acupuncture, pressure, these are all beliefs and values of people. And it's important for us to know these and to be able to provide, once again, culturally congruent care. Providing culturally respectful care. How can we do that? Practice cultural humility. Be humble, right? Conduct a cultural assessment. Follow guidelines for nursing care. Develop cultural self-awareness. Know yourself. Know your culture, your biases, and basically self-awareness. Develop cultural knowledge. Learn about the culture of other people. Accommodate cultural practices. Respect culturally based family values. Avoid mandating change. That basically means in that situation, example of the Korean lady in the seaweed soup, telling them, no, you must eat this kind of soup, right? Expecting them to change. That is inappropriate. Seek cultural assistance. If you don't understand someone's culture or what to do in a situation where there's a conflict, ask someone and seek help. But the most important thing is practicing cultural humility. What does that mean? The recognition of diversity and power imbalances among individuals, groups, or communities with the action of being open, self-aware, ego-less, flexible, exuding respect and supportive interactions, focusing on both self and the other to formulate a tailored response. Another definition is cultural humility is a process of critical self-reflection and lifelong learning, resulting in mutually positive outcomes. These are different components of a cultural assessment. Please read over these. These are things that we want to assess in our patients. For example, their beliefs, values, traditions, practices of a culture. What are culturally defined health-related needs of the individual and family? Culturally based belief systems of illness and disease. Attitudes. What is their attitude, or how much motivation do they have in seeking help from healthcare providers? This in chapter 5, box 5-6, there's some important information there. Please read over that. Guidelines for nursing care. How do we provide nursing care to our patients? And once again, box 5-5, chapter 5 in your textbook, assuring cultural competence in healthcare. Please read over these. These are very, very important. Some of the ways we can do that are developing cultural awareness. Engage with people we perceive as different from us can be threatening and difficult. It takes time. It takes more effort and patience than engaging with patients who are similar to us, right? But cultural desire refers to having the motivation to engage with patients so that you understand them from a cultural perspective. It is pivotal in the key construct of cultural competence. So that is one of the ways we can do it, by developing cultural awareness. Another one is cultural desire, right? Then accommodating cultural practices, right? Incorporate the patient's cultural background in care. Modify care to include their practices. Accommodate cultural dietary practices. Educate on therapeutic diets. This is a model that we can use as nurses. It's called the LEARN model. And it's very interesting. Actually, it's evidence-based, and it's important for us to, as nurses, to follow, right? The first one is listen to the patient, basically the patient's perspective, right? Be non-judgmental and use encouraging comments such as "tell me more," or "I understand what you're saying," right? Explain your perception of the problem to the patient. That's the next step. First, listen to them, explain your perception of the problem, right? Then acknowledge the differences between the two perceptions of the problem, but also the similarity. Recognizing the differences, but build on the similarities. What is similar between their perception and your perception? Build on that, right? Recommendations. Recommendations must involve the patient. You cannot recommend something that is only based on your perception of the problem. Negotiate a treatment plan, considering that it's beneficial to incorporate selected aspects of the patient's culture into the plan. Always try to, be accommodating to the patient. Patient is the center of our focus. Respect culturally based family roles, right? Not doing this can lead to conflict. Respect the cultural family roles. Involve family in planning, right? Avoid mandating change. This can threaten their well-being, right? Provide support and reinforcement when it is necessary to change care. Do not force patients to participate in conflicting care. Don't force them to do something that culture says is not allowed, so be accommodating. Don't force that change on them. Seek cultural assistance. It promotes mutual respect. Seek assistance from clergy, traditional healers as appropriate. Acknowledge the patient's healthcare request. Assess the patient's health literacy. Maybe they don't understand what you're saying because of a language barrier. Health literacy is the degree to which individuals have the capacity to obtain, process, and understand the basic health information and the services needed to make appropriate healthcare decisions. The health literacy level in the United States is on an average of a 6th to 7th grader, right? And so we have to assess their health literacy, be alert for their behaviors that reflect health literacy deficits. How do you know the patient is not understanding what you're explaining, right? How do you know that the basic information that you're providing is not comprehensible to them? How do you know that? Right? You look at behaviors that show that, such as having difficulty completing registration forms or health histories. If the patient is having difficulty to complete those, or to make up follow-up appointments, asking very few questions during the physical exam, they're quiet, they're not asking anything, right? And responding by just saying yes every time you ask them a question, right? Or explain something. These are behaviors that you can identify as those that show that they're not understanding your information. Use health literacy assessment tools to determine the level of the patient's health literacy. According to the Institute of Medicine, 90 million adult Americans have limited health literacy, and 20 million Americans speak poor English, and 10 million Americans do not speak English at all. Limited health literacy can be a problem for anyone. Perform culturally based physical assessments. Let the knowledge about the patient guide your assessment. Use critical thinking. Ask your patient about their home remedies and practices. Teach back in plain language. Use plain language when communicating with patient. Avoid jargon, right? And when you're teaching, use the teach back method. Basically says you plan your approach, use handouts, pictures, media, whatever is easier for the patient to understand the information with. Clarify and check again. As you're teaching, ask them again and again to clarify. Start slow and teach back consistently. Use the show me method. Clarify again, right? This diagram here shows the whole process. Please read over that and reflect on it. Using interpreters. The national class standards ensure that qualified translators translate written words. Interpreters interpret verbal words. Make sure that you use a qualified translator or interpreter when you're providing care to patients with limited English proficiency. Patients should be notified verbally and in writing of their right to receive language services. Every patient has the right to receive language services. If timely access to a translator or interpreter is not available, then you can use telephone services that a lot of hospitals provide, where you call in for an interpreter. Do not ever use the patient's friends or family member to interpret something, because family members may include their own perceptions or opinions in translation, which can greatly reduce the accuracy of translated information. And another thing to remember is, when you're using an interpreter, when you begin the patient interview with an interpreter present, you should speak in the first person, I statements, not the third person, like tell her or he said. Speak directly to the patient. And as the interpreter functions as an inconspicuous participant in the conversation, right? You're not speaking to the interpreter, you're speaking to the patient. Have the interpreter sit next to or slightly behind the patient. Look at the patient instead of looking at the interpreter, and speak in short sentences. Then wait for the interpreter to convey the information to them. Avoid using jargons, acronyms, and jokes. Attempts at humor are often lost in interpretation. Ask the patient for feedback and clarification at regular intervals. Remember, we mentioned the teach back method. Be observant of the patient's nonverbal and verbal behaviors. At the end of the conversation, thank both the patient and the interpreter. We're all done with the lecture on cultural competence and cultural sensitivity. Please go ahead and complete your readings, and I will see you in class.